Today's class is on rheumatology and it will be taken by Dr. Varun Pushkarna.
Good evening, doctors. Uh, all those who have been with us in the last two lectures, I think we've finished up to the arthritis part. Uh, we've done the ankylosing spondylitis also. Anybody from the previous class? We'll begin with ankylosing spondylitis. So, in MRCP exams, you have to remember that rheumatology carries a lot of significance because of the heightened awareness about rheumatology in UK. Basically, it is one of the flag bearers for rheumatology worldwide. So we have to remember that they tend to associate all diseases with rheumatology. So be it pericarditis, be it rheumatoid, be it arthritis, be it spondylitis, be it skin and related diseases and pyrexia of unknown origin, many times you. So basically, what you will see is that even if it is 15 questions that are expected to come from rheumatology, you will find around 20-25, including some questions which are directly from rheumatology, few of them as surrogates of rheumatology, like interstitial lung disease, pulmonary fibrosis, and then in pharmacology and epidemiology and those statistics, biostatistics, and all. So you will find more questions than promised in from rheumatology. That is why many people they just uh, later on realize that rheumatology we should have done in a better manner. We've done all sort of things in the previous classes. We've done psoriatic arthritis, we've done reactive arthritis, we've done osteo. This is all that we have done already. So today we'll be doing the leftover parts, including vasculitis and some things that we did not finish in the last class. So ankylosing spondylitis. Ankylosing means fusion. Spondylitis means anything pertaining to the spine or the axis of the body. It is a chronic inflammatory progressive disorder. Sorry for not mentioning progressive here. It basically affects. Can you see the screen, everyone? I mean, just turn on your mic and tell me if it is.
Yes, sir.
Great. So, ankylosing spondylitis, it basically begins in this butterfly area, which is we understand that this is the pelvis, and this is where it actually starts. Ankylosing spondylitis usually starts at this area, which is known as the SI joints, sacroiliac joint, and then between the junctions of all the vertebrae, it progresses, leading to bamboo spining of the whole spine, along with fixation of the sacroiliac joint, which restricts the mobility. So basically, it is the fusion of the flexibility and hence leading to stiffness. So most of the people are young, they are between 15 to 35 years of age, and they are usually men. It is associated with the HLA-B27, like we last time studied the pair diseases, which is psoriatic arthritis, ankylosing spondylitis, IBD associated arthritis, and reactive arthritis. They are all HLA-B27 associated arthritis. So mainly what we see is arthritis. Arthritis means synovitis, means wherever the bones they join with each other, at that point there is inflammation. Here it is sacroiliac joint inflammation. There is spinal fusion due to constant bone erosion and healing, spur formation. The problems start happening when the fusion starts happening. So costovertebral, costosternal. So many times you will have people coming to you with pain on the left side of the chest, worried that it could be a cardiac pain, but then it is like costochondritis that we keep saying. It could very well be ankylosing spondylitis because we usually remember sacroiliitis, but we tend to forget that costovertebral and costosternal joints may also be involved, leading to ankylosis. Also, in these patients, is very common is enthesitis. Enthesitis, that is these tendons which are the point of insertion of a muscle's belly into the bone, gets inflamed, leading to a condition known as enthesitis. Now this enthesitis can occur in a hand where the fingers are unable to move or they become stiff, or in the, as you can see here, it is the Achilles tendon which gets inflamed. As far as the symptoms are concerned, the spine, it is an inflammatory disorder. So remember always, stiffness will take over pain to much higher consideration, and it is more and worse in the morning and should last more than 30 minutes, the early morning stiffness, not only in rheumatoid arthritis, but in ankylosing spondylitis also, that gets better with activity. So this is the silver lining, that if these people continue to have good physical movement, they might have improved quality of life, leading to stiffness eventually, which may lead to a stooped posture. And you must remember, and it will be there in the exam, in the question, that these patients were tested for Schauber's test. And you need to remember Schauber's test, that is, we just tend to have a person stand by the wall and tell him to bend over, and then we measure the angle of flexibility. This demonstrates limited spinal flexibility. There is decreased chest expansion because of the involvement of the costosternal and the costovertebral joints. There is decreased chest wall expansion. Never forget that. It is an important test. Along with the joints and the tendons, the another joint, another organ involved is the eyes, which can have anterior uveitis, leading to photophobia, watering, and redness. That is, painful redness of eye may lead to blindness if not treated. Along with that, another organ involved is aorta, which leads to aortic regurgitation and consequent diseases, along with apical pulmonary fibrosis. So don't forget that lung also gets involved in ankylosing spondylitis, leading to the fibrosis of the pulmonary apices. So workup, you must remember that X-ray of the SI joint is the gold standard. Don't mark MRI. Okay? MRI of spine is not the gold standard. Although it might be the best and most accurate test, it is not the gold standard. Gold standard is X-ray. X-ray is recommended as a first line imaging by the NICE guidelines. It is gold standard also because of its accessibility, ease of getting it done. It can be used to diagnose ankylosing spondylitis. I'll give you a homework. Fill it up, that X-ray of ankylosing spondylitis staging. So you will find out how the ankylosis can be seen on the X-rays. MRI is considered to be appropriate if sacroiliitis is not detectable on X-ray. Why? In very early stages, there is only something known as bone marrow edema. There is something known as bone marrow edema. Now, this bone marrow edema cannot be seen on the X-ray. What will be needed is MRI of the joint. So MRI will tell you that, okay, fine, there is no ankylosis at the moment, but the bone marrow edema has started. Hence, the diagnosis is ankylosing spondylitis, and this helps us to diagnose it very early in the stage. And hence, getting an MRI is not criminal. Getting an MRI is tactical. When you get it done, you decide that my patient has an element of sacroiliac stiffness, and although he does not have any signs or features of sacroiliitis on X-ray, I am pretty sure that this patient has early stage ankylosing spondylitis. So let's get an MRI done. Once you get an MRI done, you can start the treatment early and also prognosticate the patient. So MRI of LS spine is most accurate. Why? Because of the bone marrow edema. Always remember this. Do not forget this. It will be there in the exam. Why MRI is better than the X-ray? It is because X-rays do not pick up the bone marrow edema, and MRI will pick it up at the earliest possible. Other findings are bamboo spine, which is fusion of the vertebral joints to each other. The problem is by the time bamboo spine happens, the patient is already like a bamboo. So there is no recovery from that point onwards. HLA-B27 can be seen in 90% of the patients, and this has come in many times in MRCP exam. This figure of 90% is very important. You must not forget it, because many times people just say it out of their memory. Okay, 50%, okay, 70%. No, it is 90% associated with ankylosing spondylitis, the HLA-B27 positivity. It is not intended for diagnosis. It is just a supportive evidence. It is just a supportive evidence to rule out other causes of spondyloarthritis. Treatment, as I told you, because there is an element of improvement with physical therapy will be a cornerstone for managing ankylosing spondylitis from the day one, along with exercise. Non-steroidals are the drug of choice. Which non-steroidal? Anyone? Anyone? Which non-steroidal is classified as first drug to be started in patients of ankylosing spondylitis?
Naproxen.
Wonderful. So the drug of choice is naproxen. Many times there is mention of ibuprofen, indomethacin, and COX-2 inhibitors. But remember that you have to know that out of all these four, all of them are non-steroidal drugs, but the first line of treatment is naproxen. Mind you, you can give it daily for a span of even 3-4 years without any significant gastric side effects and an improvement in the quality of life. Remember, this is a progressive disorder, so you will need to be on the tenterhooks. You will be on the watch out for any worsening of the disease, but some patients may remain stable on just naproxen. So consider first line treatment, that is naproxen, for managing pain and stiffness. If not, then progress to TNF inhibitors. I tell you, they are wonderful drugs. I have 2 of my patients on adalimumab, 40 microgram every second week, and they are doing wonderfully well when they were just having complications because of excessive use of non-steroidal drugs. One of them had a very bad GI bleed, leading him to a hemorrhagic shock, and eventually his hemoglobin was only 3 grams when he presented to the hospital. But now he's very happy because he's on adalimumab, and it is now literally considered as the second line therapy and a second line drug of choice. Long-term complications like any other arthritis, and people who have been on non-steroidals and sometimes on steroids, are low bone density, osteoporosis, osteopenia leading to vertebral fractures, and sometimes injury to the spinal cord. Restrictive lung disease, lung fibrosis. Remember, it is the apices which are involved. So apical lung fibrosis can be hinting towards it. Aortic valve regurgitation is a complication, and many times people die of it. Blindness due to recurrent uveitis can lead to this. So there are certain pearls for MRCP. They were not asked earlier on, but now that the questions asked from these are increasing, that is why I've specifically kept them. Those are the Bath indices, the BASDAI, or the Bath ankylosing spondylitis disease activity index. We all remember DAS28, which is the condition for which DAS28 is used.
Rheumatoid arthritis.
So that is used for rheumatoid arthritis, and Bath indices like BASDAI, they are used for ankylosing spondylitis. So it is a validated diagnostic test, and also it helps to determine the effectiveness of current drug therapy and planning to shift the therapy from non-steroidals to disease modifying biologicals. Then there are certain functional indices, activity indices, metrology index. I've just kept them for your reference. BASDAI, BASFI, BASMI, BASG, all of them are there. But then BASDAI is asked again and again. Is that clear? Ankylosing spondylitis? Okay. So now we move on to the next topic. We will do the questions also. If you want, we can do questions alongside, but I'll have to find where these questions are. Yeah. Okay. Okay. So we have them here. So it will be just, what do you say? Where is ankylosing spondylitis? It will just be few questions for you so that you can remember them. I think there are new students in this class, because otherwise if they were from previous class, they would have helped me remember where we left in the last one, because this is the red pen and we taught the last class with the black pen. Okay. All right. I would like you to participate. A 24-year-old man presents with chronic back pain and morning stiffness lasting more than an hour. He has a family history of similar condition. X-ray shows sacroiliitis. What is the most likely diagnosis? Cakewalk and ankylosing spondylitis. Okay. A 30-year-old woman with history of psoriasis presents with joint pain and fingers and toes. So this is pair or all HLA-B27. Physical exam reveals dactylitis and nail pitting. Which of the following is most characteristic of her condition? Sausage digits. Okay. Can anyone tell me, now that you guys are new, can anyone tell me, if I have to differentiate between rheumatoid arthritis and psoriatic arthritis, which joint involvement would tell me that this is not rheumatoid arthritis?
Distal
DIP. Distal
Wonderful. So
intercostal.
it is the DIP. If the DIP is involved, it is not rheumatoid arthritis. Although if PIP is the only joint involved, it can still be psoriatic. But if the DIP is involved, just DIP, or with PIP, DIP is also involved, then it goes out of the ambit of rheumatoid arthritis. Then it becomes more of a psoriatic arthritis. All right. Basic question. A 27-year-old man develops knee pain and conjunctivitis 2 weeks after a GI infection. What is the most appropriate treatment? So this is reactive arthritis.
Yes,
Remember, for pair diseases, it is the non-steroidals which are the drug of choice. Many people start these patients on steroids right away when it is not the right way of managing. It should be non-steroidals. And as I told you, naproxen works excellent even in ankylosing spondylitis and in these diseases. All right. A 35-year-old man with Crohn's disease presents with joint pain and swelling in the ankles and knees. Which type of arthritis is he most likely experiencing? So the answer is?
reactive arthritis. Enteropathic.
It is enteropathic arthritis. It is also known as IBD associated arthritis, IBDA. Okay. All right. Just a quick memory question. What is the percentage of HLA-B27 involvement with ankylosing spondylitis?
90%.
90%. Wonderful. A 45-year-old man comes with lower back pain and stiffness that improves with exercise. He also reports episodes of eye redness and pain. What genetic marker is the most associated condition? It is
27.
HLA-B27. Okay. So let me give you a question. A young boy 20 years old, diagnosed with ankylosing spondylitis 2 years back, was stable on naproxen 500 milligram daily since last 2 years. Recently, he had a GI infection, and since then, although he has recovered from GI infection, his back stiffness and pain have worsened. What is the next line of management?
Sir, TB gold interferon test followed by adalimumab.
Wonderful. So this is what I was expecting. We have to rule out that this patient does not have TB, this patient does not have HIV, hepatitis B, hepatitis C. So for all these tests we do and then move on to adalimumab. All right. So please be very, very careful. They will have first answer as adalimumab, and this will be somewhere third or fourth. So you need to rule out that these patients do not have tuberculosis, that these patients do not have HIV, they do not have hepatitis B, they do not have HIV. Only then you can start this patient on adalimumab or etanercept. This is anti TNF inhibitor therapy. Wonderful. Well answered.